Hello, this is Martin Altersberger from Heart and Lungs Ultrasound. In the first video about this lecture series about diastolic dysfunction, we extensively talked about left ventricular mechanics. Now it's time to also discuss left atrial mechanics and left atrial functions. And we want to start with the reservoir phase, also equivalent in left atrial strain to the left atrial strain reservoir phase overall. You can see here on the left-hand side a normal way of displaying left atrial strain, and the reservoir phase takes place during the left ventricular contraction. So it's actually left ventricular systole. You can see quite nicely on the left-hand side, while the left ventricle contracts, the left atrium fills. This is a very important phase because the filling defines also how in the later stage the left atrium can contract. But during left ventricular systole, we have this elastic recoil after the left atrial contraction. That leads to an expansion of the left atrium and the left atrial dimension, and therefore a reduction of left atrial pressures. Blood is then sucked in from the pulmonary veins into the left atrium. With the pulmonary venous signal, that would be the S1. Now, left ventricular contraction leads to then a displacement of the mitral valve annulus towards the apex. The left atrial roof, on the other hand, is fixed and therefore it does not move. So the left atrium is also stretched longitudinally, thus resulting in the maximal stretching and the maximal dimension at the end systole of the left ventricle. And that is also something, of course, we can measure. So elevation of left atrial dimension then leads to a decline in left atrial pressures. We said that. The right ventricular systolic pressures are simultaneously measurable at this time period. That is a translation of the pressure, so the blood flows into the left atrium due to right ventricular systolic contraction. And that is the S2 in the pulmonary venous signal. The left atrium is therefore a blood reservoir for the left ventricle, for the ventricular filling then during left ventricular systole. Left atrial filling occurs then because of stretching, the LV contraction, stretching of the atrium, but also due to the systolic RV pressures and also due to the compliance of the left atrium itself. On the left-hand side, you see a pulmonary venous signal with the two waves, initially the S1, the S2, and the D wave. Continuing with the next phase, it's the conduit phase of the left atrium. You can see a displayment of a 3D left atrial strain, where you also have the same phases as in 2D strain. The conduit phase of the left atrium is measurable in the left atrial strain, of course, the conduit phase. And that is the phase when the mitral valve opens until the time interval the left atrium contracts. And that you can see here on this nice graph over here. So here we have the left atrial reservoir phase, and the conduit phase is until the left atrial contraction. So in atrial fibrillation, of course, this phase then lasts until the end of diastole, because we do not have a left atrial contraction phase, because the LASct, left atrial strain contraction, is lacking, it's missing. Blood volume from the pulmonary veins are now directly forwarded into the left ventricle without this left atrial storage in between. The stroke volume of the left ventricle is therefore the volume of the reservoir phase, existed before mitral valve opening, and the left atrial conduit phase, the flow through the pulmonary veins and the left atrium into the left ventricle. Of course, that is only the case when there is no relevant aortic or mitral regurgitation present. This mid-diastolic emptying with this mid-diastolic passive shortening of the left atrium occurs in this phase. The volume shift can also be calculated. So the left atrial reservoir, left ventricular filling, when you have the LA maximal volume minus the LA minimal volume. The left atrial conduit, left ventricular filling, is the left ventricular systolic volume minus the left atrial reservoir volume. This calculation then, of course, the insignificant backflow volume into the pulmonary veins that also happens to a certain degree, but no real measurement is possible in echocardiography. This AR, this reflow, it's called AR as well, is very, very small. The conduit phase is in the pulmonary venous signal, the D wave. So the pulmonary veins also can show this conduit phase of the left atrium. Now we move on to the contraction of the left atrium, the LASct, the left atrial strain contraction phase. So when you have on this side here, the left atrial strain, we have the reservoir strain, the conduit strain, and directly before the P wave, there is the contraction phase starting. And this contraction phase is responsible, we said it, for 10 to 20% of left ventricular filling. So the LA systole is an active action of myocardial shortening. In the elderly, they are more dependent on this phase. So in the elderly, the atrial contraction comes to 35 to 40% of left ventricular filling. A small shift, we said that already, is seen backwards into the pulmonary veins in healthy individuals as well. This is the AR phase. If it is also in the case of elevated filling pressures, the AR becomes more prominent and also measurable. So the left ventricular filling is dependent, of course, we said, on the LA volume, the left ventricular suction, but also the pressure difference in between the left atrium and the left ventricle. Furthermore, the stiffness of the left ventricle is something which is very important to understand. So in amyloid heart disease, we have a reduced longitudinal function. The left ventricle is, of course, more stiff and filling pressures are higher than in normal individuals. We already discussed the left atrial contraction phase as well. So also left atrial contraction is important, not only the left atrial volume by means of filling of the left ventricle. Now we have a case of a normal situation. We have this normal, nice filling of the heart, the normal, nice contraction of the left atrium, the normal left atrial reservoir phase as well. Now I want to continue with the first summary. So overall, the left ventricular filling pressures cannot be measured entirely exactly in echocardiography, but we can estimate them well. But all the parameters have several limitations. And now we are going to discuss several parameters we need to measure to identify elevated or normal filling pressures. And we want to start with the so-called E to A ratio. We have here a Doppler measurement, we have a pulsed wave Doppler measurement, and we place the pulsed wave Doppler in that area. So at the tips of the mitral valve leaflet. So really at the tips, not in the center of the mitral valve, but really in the tips of the mitral valve leaflet. And then we get an image. We have a E wave. Here we have the phase of diastasis and the A wave. The same is seen here, so an E and an A wave. We also see here already a problem, a limitation. Here we have aortic regurgitation. So the signal of AR is blocking our view, so to speak, to see the pulsed wave Doppler signal. The Doppler per se, the sample volume should be in the range of 5, 6, 7, 8 millimeters. So when you measure normally the inflow, also the LVOT signal, the sample volume should be a little bit larger compared when you measure in the pulmonary veins or the pulmonary venous signal. So of course this measurement as a standalone has several limitations, not only AR, but it is a Doppler measurement. Image quality is important. You do not have an A wave when you have atrial fibrillation and tachycardia, bradycardia. It's harder to differentiate. And the first measurement, the E wave, we also want to discuss. And here we have several automatic measurements in a case of restrictive filling in a non-dilated left ventricular cardiomyopathy. Here you can see very nicely delineated the very large E and the very small A wave. Here are several measurements as well. Also the deceleration time is displayed. We will discuss it in a later stage, but this E wave denotes the early left ventricular filling. In this case, we have a sick left ventricle in a non-dilated left ventricular cardiomyopathy. This very large E and this very small A wave denotes automatically elevated filling pressures. We will discuss that when we talk about the guidelines as well. So the early left ventricular filling, the E wave, when you measure the E wave, it's simply the first wave, so the filling of the left ventricle, the early diastole. It is not usable for directly measuring the filling pressures. Unfortunately, like we know it from the SPAP measurements via the modified Bernoulli equation, because there's an inertia effect of the blood because of the mitral valve. So it doesn't give you the direct pressures, but it can give you information about the pressure differences of the left atrium and the left ventricle. In young and healthy athletes, the rapid relaxation leads to an extremely low left ventricular and diastolic pressure. So the transmitral pressure difference is elevated, and therefore the left ventricle sucks in all the blood, also resulting in a very high E wave. So this very tall and large E wave that is present in severely sick hearts, but also in young, healthy individuals. Limitations, there are plenty, of course. If you have a relevant MR and a relevant mitral stenosis, the higher E is independent of diastolic dysfunction, because you need for mitral regurgitation the volume being pushed into the left ventricle, because there is also volume lost from the ventricle during systole due to mitral regurgitation into the left atrium. In MS, you have, of course, a gradient because of mitral stenosis, so it doesn't denote elevated filling pressures per se. If you have a relevant aortic regurgitation, also left ventricular and diastolic pressures rise. A is filling independent, so the smaller A and the higher E to A ratio is therefore there because of the reduced left atrial and left ventricular pressure difference in end diastole. Also in coronary artery disease, or HCMP, there is a worsening of this elastic recoil. So the measurement of the E wave has almost no correlation per se with left ventricular and diastolic pressures. The deceleration time, you already have seen it. We take a look at it again. The deceleration time you measure from the peak E wave down to the zero line. The deceleration time is the time interval where the left ventricle and left atrial pressures invert. So there's a deceleration force, high filling pressures, high flow, rapid elevation in pressures, and a rapid change therefore results in a very short deceleration time. Normally this time interval when you're below 50 is around 220 or higher milliseconds. If you're above 50, it's around 240 milliseconds. Elevated filling pressures are there when the deceleration time is very, very short. So below 150, even better below 140 milliseconds. But be aware again, young healthy athletes can also have a relatively short deceleration time. So it's a good marker for elevated filling pressures when it is very, very short. But if it is in a higher range, around 150 to 200 milliseconds, we cannot really denote the filling pressures are elevated just by means of this one measurement. Next measurement we have at hand is the A wave. The A wave is the active atrial contraction. So the high pressure gradients in between the left atrium and the left ventricle in elevated filling pressures result in a very small A wave. On the left-hand side, we have such an example of a very large E wave. Let me just show you here. We have the signal. This is the E wave and diastasis, and the very small A wave here, second very small A wave. This is an example of a restrictive filling with a very small A wave and a very large pre-A that is also seen in this case. You can see also there is some flow in diastasis happening, and this denotes definitely elevation of filling pressures. So the limitations, of course, the deceleration time of the E wave and the A wave. Again, tachycardia and E to A fusion happens in tachycardia. If you have aortic regurgitation, significant bundle branch block, so left bundle branch block, significant AV block, and many, many, many more. Also for the A wave, of course, in atrial fibrillation, you do not have atrial contraction, so you cannot measure an A wave at all. The next measurement we have to look at is a ratio. So the ratio of this E wave and the A wave. I talked about it already, and you have normally a ratio around 1 to 2. In young healthy individuals, it should be above 1 or 0.8. When it is below, you always have to question, is there hypovolemia in young individuals present? In athletes, this ratio exceeds sometimes 2. In endurance athletes, even 3. So it is like in a pathological restrictive filling when the E to A ratio is also above 2. So you always take a look at those two, you have the E wave and the A wave. And in this case, you have an E to A fusion in a patient with Epstein's anomaly. The deceleration time is prolonged. The pre-A is above 20. You see here, this is the pre-A before the A wave, centimeters per second. And there you have this E to A almost fusion. And in this case, it's almost 1. So even a little bit below 1. So you see the E wave, it's around 50 centimeters, and the A wave, it's a little bit above 50 centimeters per second, and you calculate this ratio. In a HFpEF setting, the pre-A wave normally is below 20 centimeters per second. So before the A, there is little fall. In case of a prolonged deceleration time, as we also see it here, the A wave is directly attached to the E wave, and the pre-A velocity is relatively high. So also in this case, around 30 to 40 centimeters per second, so above 20 centimeters per second, therefore resulting in a higher overall A velocity. In HFpEF, on the other hand, so heart failure with preserved ejection fraction, keep in mind the E wave per se is often above 1 meter per second, so 100 centimeters per second. To identify this pre-A, you can also reduce the wall filter to see it in case of lower velocities if you want. The ratio of E to A, in this case, we do see an E to A of 1.22 in a case of hypertrophic cardiomyopathy in sinus bradycardia with a very low pre-A in this case. So let me show you just quickly. Here is the E wave. This is all diastasis, a patient with hypertrophic cardiomyopathy, bradycardia due to beta blocker therapy, and this A wave seen over here and the very small pre-A velocities. So if filling pressures are rising, left ventricle and left atrial compliance is reduced, the left atrial pressures rise, the E wave also rises. It's higher because of the higher pressures and the higher pressure difference and gradient. So left ventricular and diastolic pressures lead to a rise in left atrial afterload and a reduction of the end diastolic left atrial left ventricular pressure difference. So the A wave will be smaller up to this restrictive filling where the E is very large and the A is very small. And that explanation before, that was the idea behind this pattern of pseudo-normalization. So initially when the heart gets a little bit stiffer, have a smaller E and a larger A wave that denotes that there is a diastolic, or there could be a diastolic problem present, but then in the later stages of diastolic dysfunction due to the rise in pressures, the E wave becomes higher, the A wave becomes smaller until it reaches this restrictive filling. So this pseudonormalization is not existent in the current guidelines, just to understand the pressure differences, why it was called that way. Now, note that E to A plus minus the deceleration time, they are also insufficient measurements for any valid or accurate description of left ventricular, left atrial filling pressures, except, and that's very important, the restrictive filling pattern. The restrictive filling pattern means an E to A ratio above 2, thus being a diagnostic tool for elevation of filling pressures. Now let's continue with this very low A wave. The A wave can be very small. In this case, we have a so-called atrial stunning after cardioversion. So after cardioversion, you do not have active atrial contraction. Therefore, also patients need anticoagulation therapy. The A can be very small. So in this case, after cardioversion, it's called weak left atrium. In cardiomyopathy, because of the fibrosis of the left atrium after heart transplant, also in significant AR, in a very short PR interval, in the case that left ventricular contraction starts even though left atrial contraction is not even done. And in A flood, they can also be very small. There are many A's, but none of them are measurable. So keep in mind the A wave has several reasons why it can be also very, very small. He has two distinct problems with the measuring of E to A and the wave interpretation. We have this inflow of the mitral valve, and you also see aortic regurgitation. In this case, this is a patient with amyloid heart disease. You have here the AR, and the AR directly points towards where you would measure the mitral valve inflow, so the E to A. And here I have a patient who is tachycardic with around 100 heart rate or 100 beats per minute. You have a very small E and a larger A wave with this E to A fusion. Now here's an example of aortic regurgitation, where you see this larger E wave here. I have the aortic regurgitation in the field of view, and the A wave seen over here. Here's a better delineation of the E wave. It would be an L wave as well, and the A wave. So this is actually almost denoting a restrictive filling pattern. Keep in mind that's also significant. AR is present. Furthermore, in atrial fibrillation, you do not have an A wave, but you see here several E waves. When you have atrial fibrillation, you should find a mean measurement of around 5 to 10 inflow signals, so 5 to 10 E waves. The next measurement we have to take a look at is the so-called tissue Doppler imaging. Tissue Doppler displays velocities of the tissue. So we have here a special preset, and we place the pulsed wave Doppler. Also, the sample volume should be in the range of 5, 6, 7, 8 millimeters, so not too small, not too large. And we place it just above the mitral valve annulus medial and just above the mitral valve annulus lateral. And then you get this tissue Doppler signal. That's the E prime, the A prime, and we have the same waves. We have an IVRT, then we have the E prime diastasis A prime, and the IVCT, and then systole. So the left atrium and the left ventricle, they move during systole. We said that, and they also move during diastole. During systole, the mitral valve ring moves towards the apex, stretching also the left atrium. So downwards to the apex. That's the so-called S prime, the systole. You have that in the right ventricular measurements. You also have them in the left ventricular measurements. So with this, the left atrium is stretched, and after maximal contraction, relaxation follows. So in early diastole, the left atrium is compressed because of this E prime, so the excursion. And during left atrial contraction, that's late diastole, a second movement follows upwards to the base of the heart, and that's the so-called A prime. So we have two movements, in E prime and an A prime. The E prime pathological cutoffs have to be known. If you are very accurate, they are the following, which are the most reliable measurements, also dependent on the age of the patient. So in male patients 18 to 40, the septal E prime is pathological when it's below 7 centimeters per second, lateral below 9 centimeters per second. For females, the values are a bit higher, septal below 8, lateral below 11 centimeters per second. In all individuals 41 aged to 65, septal below 5 and lateral below 6 is pathological. All above 65, septal and lateral is septal 4 centimeters, the cutoff, and lateral 5 centimeters per second. On the left-hand side, I want to show you again the signal. Here is the IVRT measured. You see here, that's the IVRT measurement, again an IVRT measurement. And here we have the lateral E prime diastasis and the very small A prime and an IVCT and then S prime. So the tissue Doppler measurement gives already a lot of information, but remember, those are the very accurate, but also not the cutoffs which are mentioned in our current guidelines. So keep them in mind just to get an idea what the normal values are, and later we discuss what the guidelines say. Medial normally is a bit lower than the lateral measurement. Why? Because there's less motion septally due to the aortic valve, the intervalvular fibrosa, the anterior mitral valve leaflet, and the non-coronary cusp meeting. And an exception can be found in constriction. So in constrictive pericarditis, when you have really a calcification of the lateral wall of the left heart as well, you have the so-called annulus paradoxus. Then the septal TDI measurement of E prime is higher than the lateral one. But that is, as far as I know, the only exception. There are several limitations. Those values are variable. There is no absolute rule out of elevated filling pressures in case of high E prime values. So this is another important information to understand and to know when to think about those measurements. So no single measurement rules in or rules out, except for example, the restrictive filling pattern, elevation of filling pressures. So continuing with the next measurement, we can measure an E to E prime ratio. So the E wave versus the E prime wave can create a ratio. And the E is elevated, we said already, in high filling pressures. The E prime can adapt, so volume overload, for example. So E to E prime stays initially normal due to the adaptation of the E prime. Then in significantly elevated filling pressures due to structural left ventricular disease, the E to E prime stays small and only E is elevated. So the E stays large, the E prime stays small, and we have then an elevation of E to E prime. To discuss the cutoffs, when you have a cutoff of medial and lateral below 14, E to E prime is basically considered normal. Whereas then 8 to 14 is still a gray zone, because we do not know if filling pressures are normal. In case of an E to E prime ratio, medial and lateral, the normal situation of left ventricular and diastolic pressures are highly likely. Above 14, pressures are generally elevated, resulting in a pulmonary capillary wedge pressure, we estimate with this, of above 15. The septal E to E prime ratio is 13, the lateral cutoff would be 15. And the mean, and that is important, the mean cutoff of an E to E prime ratio, also displayed in our current guidelines, is 14. On the left-hand side, we can see here, just to explain the E wave, the A wave, here we would have the deceleration time, and we have here the E to A ratio, which is below 1, even below 0.8. And we have here a medial tissue Doppler signal, that's the E prime, that's the A prime. You can identify here the S prime again, IVRT, IVCT, and a lateral measurement. We have the E prime, the A prime, the IVCT, S prime, IVRT, and E prime again. And together with this ratio, we can get more information about filling pressures. With this measurement, we also have to discuss limitations. There are also plenty of limitations. For example, left bundle branch block, pacemaker, if you have a wall motion abnormality in the lateral regions, in the septal regions of the heart, if you have significant mitral annular calcification, it is still a Doppler measurement. So all the Doppler measurements are angle dependent. If you have a mitral valve repair or replacement post cardiac surgery, the septal E prime can also be reduced. So we are not sure what we actually can measure there. In constriction, we said we have this annulus paradoxus. In severe MR, mitral stenosis, also in significant aortic regurgitation, it has to be used with caution. So it's another puzzle piece, but all the parameters have limitations. So all measurements are angle and volume, so filling dependent, E to E prime less, but still there are significant pitfalls in the angle dependency and volume changes. All parameters so far we discussed perform especially well in patients with reduced ejection fraction. So still we have limitations in patients with heart failure with preserved ejection fraction. To summarize this video, we have several parameters already at hand to define diastolic dysfunction and also to identify elevated filling pressures, but all those have limitations. E to A ratio, Doppler, AR, image quality, atrial fibrillation, you do not have an R. In tachycardia, you have this E to A fusion. We discussed this already, the E to E prime ratio, also it's a Doppler measurement. Image quality for all the measurements is essential. Mitral annular calcification could cause a problem. Operations on the mitral valve, replacement and repair, we do not really know the cutoff values, and also if you have wall motion abnormalities as well.